A little bit more difficult is to find that abnormal electrical activity in the brain. And I'm going to talk a little bit more about that later. The other word that we obviously have to define is epilepsy, a word that obviously has a lot of stigma associated with it, and oftentimes people refer to it rather as a seizure disorder. The word epilepsy actually comes from a Greek word that's epilambanein, which just means to seize or to attack. And we consider someone to have epilepsy when they have two unprovoked seizures, meaning seizures that were not caused by any fever, infection, or drug. Just lately, the International League Against Epilepsy has actually expanded that a little bit and said, well, if you have had one seizure and there's a greater than 60% chance of having a second seizure, then we can talk about epilepsy or seizure disorder. And now, how do we know whether there's a higher than 60% chance of having a seizure? One of the things is if you have an abnormal EEG that shows a seizure discharge after a first seizure. That is when, oftentimes, at least when we treat adult patients, we start thinking about a anti-seizure medication, because we know the chance of having another seizure is high, and higher than 60%. Now, how common is epilepsy and seizures in general? We think that in the United States there are close to 3 million people who have epilepsy. Worldwide, that actually comes to about 65 million people. And here in Connecticut, we think there are about 60,000 people that live with epilepsy. Every year in the United States, another 200,000 people will develop epilepsy, which actually comes to 1 in 26 people in the United States who will develop epilepsy. And that is really the fourth most common neurological disorder. So it is really not that rare. The chance of having a seizure through the age of 74 is estimated at 3.1%. Only 1% though of people will go on to have repeated seizure or epilepsy. We really find very little differences in ethnic backgrounds as to who has seizures and epilepsy. It can really affect all ages, all races, and all ethnic backgrounds. And the CDC estimates that the annual costs in the United States, direct and indirect, due to epilepsy is $15.5 billion. Now, just showing as far as who, again, will start having epilepsy by age. On the left side, we have newborns that often have metabolic or genetic disorders, so there's a slightly higher incidence of developing epilepsy. The incidence goes slightly down into the when we're in the 20 or 30 year age range, and then after age 50 it really goes up again. And we think that this uptick later in life is due to people having strokes, which is obviously a disease we see more in the elderly, and also dementias like Alzheimer's dementia has a slightly higher risk of also having seizures, also something that happens when we get older. Now, the classification of seizures, this is done by the International League Against Epilepsy. The last time that they looked at this was in a sort of over several years between 2005, 2009, and they basically said, all right, we have generalized seizures. Those are seizures that really affect the entire brain, that can start primarily in the entire brain, then we would call that primary generalized, or secondary generalized if they start in one little part of the brain and then spread all over. And this is sort of just a description of what you see when the person is having a seizure. So you can see tonic-clonic activity. That is what was used to be referred to as grand mal seizures, where people fall to the floor, shake all over. And the term grand mal is really outdated, and we are trying to get rid of it because it's really called translated as the great bad thing, and that certainly does not help the stigma associated with it. We have other seizures like absence seizures. That is what was referred to in the past as petit mal, where especially more commonly seen in kids, they just have some staring without any other motor manifestations. And then we have some other description, myoclonic, which are sort of just these jerks that some people have with their seizures. And then you can have just clonic or tonic response, which is either very stiff with arms and legs extended or flexed. Apart from the generalized seizures, the classification has focal seizures, and focal seizures also come in different shapes and forms. They can either be simple motor seizures where there's just a twitching seen either in the face or the arm or the leg, and the patient is totally with it and knows what's going on. And then of course, we have those seizures where people are out of it. They are just sort of smacking their lips. They might be twitching somewhere, but they are still standing or sitting, but are not aware of what's going on around them. Those used to be called complex partial seizures. Some people nowadays prefer the term dyscognitive seizures. Obviously, we have some unknown seizures where it's very difficult to put them in any of the classifications. And new in this classification are the epileptic spasms. Those are things we usually see in neonates or very young babies, where they can have spasms due to seizures. And really everything else is, when we talk about what is the cause of the seizures, is something that we always look for, and different ages we see different types of seizures. Unfortunately, as probably everyone is well aware, the majority of patients, we do not have a known cause or identifiable cause of seizures. That's probably about 2/3 of them. But at least when we stick to these descriptions, like I talked about these classifications, then that is just a starting point trying to understand what is going on. Generally, when we see a patient in the office where the question of seizures is raised, a lot is about the history and getting a good understanding of what the person is experiencing and also what witness to the events are seeing. Oftentimes it is helpful to actually get a video as well, because the pictures are more than 1,000 words, and very helpful in trying to understand what is happening. We generally do a physical examination, including a generalized neurological examination. And then there, for any first-time seizures, the recommendation is to get an electroencephalogram or EEG, and then some type of imaging of the brain. Later on, if we are not sure or there are some other questions, then we go on to video EEG monitoring. So like I said earlier, the whole idea about trying to understand whether this is a seizure or not is not so easy necessarily, because there are a lot of things that can cause a change in awareness or change in behavior or sensation, but they are not associated with abnormal electrical activity. So in the differential for seizures, we have anxiety disorder and panic attacks. There's some cardiac arrhythmias and TIAs, which are transient ischemic attacks, or CVAs, which are ischemic strokes, can look like the person is having a seizure. Obviously, drug toxicity can cause symptoms similar to seizures. Migraines can do that. Mood disorder as well as conversion disorder, those patients can appear as if they are having seizures. Hypotension or lowering of blood pressure, orthostatic, just means with change in position, can cause people to pass out. Vasovagal syncope or fainting, another cause for people to pass out, where oftentimes the question of seizure is raised. Tremors and tics can look like seizures, and vestibular disorder, which is something to do with dizziness and vertigo due to inner ear problems, can all cause pictures that are very similar to what we see with seizures. So we like to capture the seizure on an EEG. EEG is a brainwave test where electrodes are put over the head and electrical activity is recorded. And then we get these squiggly lines, as you see on this page. On the left side, you see sort of normal brain activity. And you can clearly see in the middle of the page where suddenly all the squiggly lines seemingly do the same thing. And that is what we call a primary generalized seizure. The whole brain is firing off at the same time. Those are patients that will not get any warning, and this is sort of a classic picture of a childhood absence seizure, where kids will just start staring and do that for a couple of seconds before coming out of it again. So that, as I said, is a primary generalized seizure. We think these kind of seizures are due to problems in the networking of the brain cells or neurons. So that is something that we are born with, and it can take several years, sometimes decades, before patients will have their first seizure. But when we see an EEG where the whole brain fires off at the same time, we think of that as being an inherited form of epilepsy. And the most common types are the childhood absence epilepsy. That is something that usually happens or starts between ages 3 to 12, and 12 is already a little old for that. Those are, like I said, these classic staring spells can be brought on by hyperventilation, and vast majority of these kids will outgrow their seizures by the end of their adolescence. And generalized tonic-clonic seizures are very rare in this form of epilepsy. The second most common form of primary generalized epilepsy is the juvenile myoclonic epilepsy. As the name says, it happens in the teenage years, sort of around age 16 to 18. Those are patients that can have generalized tonic-clonic seizures. Like I said, there's shaking all over. Oftentimes they will notice first, though, that they have these myoclonic jerks early in the morning, especially when they are sleep deprived. They will have these sudden involuntary twitches, and 40 to 50% of these patients will have a family history of epilepsy, and there's actually a gene that has been identified for this type of epilepsy. Now, more common, at least in adults, though, is what we see on this EEG, where the arrow is, you can see this spike in a slow wave, as we call it. That's a seizure discharge or epileptiform discharge. And based on where this discharge is where we think the seizure is coming from. In this patient, it's coming from the left temporal head region, from the side of the head on the left side. And that's really where the EEG is very helpful, because it helps us to determine where the seizures are coming from. And when we then do an imaging study, that obviously is a region of the brain that we will focus on, especially to try and find any kind of structural problem that might be triggering the seizures. And that's why we need an imaging study. It's either a CAT scan or an MRI. MRI does give us a better resolution of the brain, but obviously it is a little bit more involved, takes longer to do, and therefore the patient has to be able to participate with that. And these are sort of the pictures you can get with that MRI. In this case, actually, on this MRI, we see this very thick gray matter where you see these black arrows. Those are neurons that ended up in the wrong spot as the brain developed, where when the brain is developing, the neurons that do all the thinking, they are born deep inside the brain. Then they have to migrate to the surface of the brain and make up the different layers of the brain. And if anything goes awry there, sometimes the neurons end up in the wrong spot, and then they are more likely to be irritated and trigger seizures. So with all of this, the EEG especially, we're trying to figure out where in the brain are the seizures coming from. And the most common area where we see seizures coming from is the temporal lobe here in green. That is the most epileptogenic part of the brain. This is followed by the frontal lobe here in yellow, and then followed by the parietal lobe in pink, and rarely do we see seizures coming from the occipital lobe or the back of the head, which is here in purple. And really, we can try to figure it out by what the patient is describing as what's happening to them as the seizure progresses, or we can figure it out by that EEG to see where those seizure discharges are coming from. Now, the most common type of epilepsy in the adult is the temporal lobe epilepsy, meaning from the side of the brain. And in the temporal lobe, we have the neocortical, which is the surface of the brain, or very deep inside the temporal lobe. That is, we differentiate those two areas. So 80% of patients that have these seizures have had at least one seizure in early childhood. Most common type of seizures here are auras followed by the whole passing out, and then sometimes they can generalize, and people have, again, generalized tonic-clonic seizures. Oftentimes, we find scarring of the temporal lobe as the cause of these epilepsies. Second most common type in adults, like I said, is the frontal lobe as the source of the seizures. Those are give us much more strange motor symptoms. People can be bicycling, where they look like they're bicycling while lying in bed. They can have sort of what we call fencing posture, one arm stretched out and one arm flexed. They are often happens out of sleep in the early morning hours. They often generalize and can occur in clusters. Now, just to go through it as far as what does a complex partial seizures, or nowadays called dyscognitive seizure, really looks like. It can be preceded by an aura that is seconds to minutes. And the aura is what we generally ask patients about as far as did they get any kind of warning before the seizure started. The aura, sometimes people have very tough time describing what is happening to them, but if they can have all these different sensations, whether butterflies in the stomach, palpitations. They can think that they're having an out-of-body experience. They can have panic attacks, and all of those symptoms can help us, again, localize where those seizures are coming from in the temporal lobe. Now, the aura is followed by an arrest response, where the person will stop doing what they're doing, There might be some staring and some oral automatism where they're smacking their lips or they're sort of seemingly fidgeting with their hands that can last 2 to 3 minutes, and then sometimes the seizure will continue, and then people will pass out, fall over, and have the whole generalized tonic-clonic activity, that shaking of arms and legs. And that's usually when you can hear complaints about urinary incontinence and tongue biting, and sometimes a scream before that. The primary generalized epilepsies I was talking about earlier, like the juvenile myoclonic epilepsies, they basically go right into the generalized tonic-clonic activity without any warnings beforehand. All of the seizures, whether they are focal or primary generalized, have a certain amount of post-ictal period, which means the period after the seizure is over, where patients can be very confused, exhausted. They can complain of headaches and muscle aches. They might not know what happened to them, and these can last minutes to hours. Actually, in people with childhood absence epilepsies, is what petit mal it was called in the past, often only have seconds, and they're immediately back to where they were beforehand. Now, changing topics a little bit, going to treatment now. When we think about treating patients with seizures and epilepsy, the goal has to be no seizures. And obviously we would like to do that with no side effects. That's the goal. That does not mean that we can always achieve that, unfortunately, but at least we have to strive to that. Also, though, we have to think about long-term quality of life benefits, safety, interaction with other medications, and ease of compliance with medication, which just means if you have a medication that has to be taken 4 times a day, it is guaranteed that won't happen every day. So quality of life is important. The studies have shown that more and more now, that only if patients are absolutely seizure-free is their quality of life comparable to the general population. That's why we shouldn't be satisfied if we can reduce the seizures from 1 a month to once every 6 months, because it still affects the quality of life of patients. And any breakthrough seizure has a significant impact on people's life, increases the risk of anxiety, low self-esteem, and more problems with social interactions. Treatments in general, because people have realized seizures, that there are seizures since the ancient Greeks. So, and this is sort of partly because of the poor understanding of what is happening, that there is so much stigma associated with seizures. But treatments have included everything from rubbing the head with oil, ingesting silver nitrate, wearing a bracelet made from a nail of a wrecked ship, exorcism, pilgrimages, eating certain herbs and plants. And the ancient Egyptians also used trepanation, which is drilling holes into the skull to let out the evil spirits, all to try and treat patients with seizures. In the late 19th century is really the first time that we started having a treatment. This was bromide, which is not used anymore. And I'm just going to go through basically the years that the medications came out. Phenobarbital, which is probably, because of its cheap price, one of the most widely prescribed seizure medications worldwide, came around 1912. 1920, we already learned about the ketogenic diet, and I'll talk a little about that later. 1938 is when Dilantin came around as one of the first seizure medications, followed by trimethadione for absence seizures. And then the FDA changed slightly their requirements for medications, because before 1960, the drug companies only had to show that the medication was not toxic. They did not have to prove any kind of efficacy. In 1960, the FDA changed that and said the drugs have to be efficacious before they can be approved, and you can see nothing happened anymore as far as coming out with new seizure medications for the next 14 years. Really, the only thing that came out was Valium, which can be used for seizures. We don't use it on a regular basis, really. And then 74 was Tegretol or carbamazepine, followed by Depakote in 1978. In those three, the phenytoin, Dilantin, carbamazepine, or Tegretol, and valproic acid or Depakote are considered first-generation anti-seizure medications. At that point, though, the National Institutes of Neurological Disorders at the NIH, as well as academia and industry, came together and said, well, we need some more treatments for seizures. And they started to develop anti-epileptic drugs together, and that's when we then saw felbamate and gabapentin in 93, lamotrigine or Lamictal in 94. 97, we got a device approved that was a vagal nerve stimulator. I'll talk about that also a little later. Then we have topiramate or Topamax, targabine or Gabatril, not used that often anymore. 2000, we saw the Keppra, Trileptal, and Zonisamide come to market. And then the list goes on. And then 2005, we have Lyrica, and these are now really sort of the third generations. They are all still brand name medication, which makes them more expensive. That's the Lyrica, Vimpat, Banzel, Sabril, Potiga, Onfi, Fycompa, and the last one, 2013, was the Aptiom. Now, with all these new medications, we'd think that we'd have a better control of seizures, but unfortunately, that is not the case, and we still have 1/3 of patients that cannot be controlled with medications, despite all these new seizure medications. However, we do have a bigger armamentarium, we have more choices, and therefore sometimes it is easier to find medications that people tolerate without any side effects. Like I mentioned, 2/3 of patients will become seizure-free. The one last third, we do not find medication, and we consider those medically refractory or intractable patients. Now, some of these patients, though, will remain on their anti-epileptic medication for many, many years, and that's why we also have to think about the long-term effects of these medications and trying to reduce the negative impact on quality of life. Treatment issues can be varied, and we have the immediate questions like serious adverse effects like rashes or aplastic anemia where no more blood cells are made. Obviously, efficacy is important. If the medication is not efficacious, then there's no really reason to use it. Fatigue or drowsiness and dizziness are common complaints of patients taking seizure medications. Memory problems is something that often comes up. And then the simplicity of titration, how easy is it to start that medication, all of which will impact on what medication we might consider for anyone. Now, long-term side effects, and those are things that we don't necessarily see immediately, but can have a big impact on someone's quality of life, is bone health, especially with the first-generation anti-epileptic medications. We have seen an increase in the risk of developing osteoporosis and osteopenia. Medications like Depakote are associated with weight gain and hair loss. Dilantin is where we see overgrowing of gums and also in neuropathy. Those, again, things that we don't necessarily can predict who is going to get them, but need to be considered. Now, there are some specific side effects or treatment effects for certain patient populations. Women, for instance, we need to be aware of interaction with birth control pills and fertility issues, as well as pregnancy, and then in the elderly and people with other illnesses or chronic illnesses, we have to think about drug-drug interactions, change in metabolisms, more susceptibility to side effects, and forgetfulness, which can affect compliance. The other things that, and this is something every patient who has epilepsy should always talk to their doctor about, are the associated conditions that we see in patients with epilepsy, like depression and anxiety, headaches, cognitive impairments, as mentioned before, due to either medications or seizures, and sleep disturbances. Those are things that go together with, or often seen together with epilepsy, sometimes are ignored or not spoken about because everyone is focusing on the seizure treatment, but these should be addressed as well. This is just a slide of some of the commonly used seizure medication, their effect on weight, because it always comes up, especially in girls and women, because we don't want to cause weight gain that would also decrease quality of life. We think that lamivudine and or Lamictal and Keppra, levetiracetam, are weight neutral. On Topomax, zonisamide, and felbamate, people are more likely to lose weight, and gabapentin, Tegretol, Depakote, and Lyrica more commonly seen weight gain. That does not mean that everyone will do that, but the majority would fall into those categories. Now, are there other treatments for the 1/3 of patients who do not respond to medication that we call intractable? And yes, we have epilepsy surgery, where you're trying to remove the area of the brain that is causing the seizures in the right kind of patient. That can be very successful. Especially in kids, we have the ketogenic diet, which is basically an Atkins diet on steroids with high fat content, low carbohydrates, and low protein diet. That is something that needs close monitoring by the physician, and often you need a nutritionist and dietitian, and is done in tertiary epilepsy centers only. We have some devices. One we mentioned earlier in that list of medications, the vagal nerve stimulators for people who can't really have epilepsy surgery, who still have seizures despite their medications. This is a pacemaker-like device that sends intermittent stimuli over wires wrapped around the vagal nerve into the brain, trying to disrupt this fast synchronization of seizure discharges. And then the last device that was approved is the neuropacer, which is an implantable neurostimulator that identifies seizures as they start and sends in electrical impulses to stop the seizure from spreading. And I think I got some pictures here. Is the vagal nerve stimulator. So it looks like a little pacemaker that gets implanted over the left chest. And then there's the little wire that goes around the vagal nerve usually on the left side, and sends in electrical impulses, and you can program the device and you can interrogate it from the outside, and thereby changing the settings to get optimal benefit from the device. The neuropacer is similar as a little computer actually that gets implanted into the skull, and then there have to be electrodes on the brain or in the brain in the area where the seizures are coming from. The computer learns what the seizure discharges look like over time, and then when it identifies them, it sends in a little electrical impulse to stop the seizure from spreading. Now, just for some general remarks, seizure first aid, people always talk about it. Most importantly, you want to make sure that the patient is safe. So if they're having a seizure, you're seeing them, they're standing, you lower them to the floor. If they're sitting safely, they can stay sitting, otherwise also lower them to the floor. You want to remove any loose objects in the vicinity so that they can't fall onto the patient when they're having a seizure. Do not try to hold the patient down, and do not try to place objects in the patient's mouth, both of which can only lead to injury and should be avoided at all costs. It's really important to stay with the person and to stay calm. You want to pay attention to how long the seizure lasts, and seizures generally, when you have to witness them, seem like they go on for an eternity. So it does help to look at a watch to get an idea. Once the seizure is over, the patient should be placed on her or his side, and you want to make sure that their breathing is okay. And you want to know when to call 911. Not every seizure requires a visit to the emergency room. If a patient has known seizures and it is the same seizure as they're used to, and it is less than 5 minutes, there is no need to go to the emergency room. If the seizures last longer than 5 minutes, or they injure themselves, or there is any if there's a difference in their type of seizures, then a visit to the emergency room would be very reasonable. This is for anyone who has seizures, and you want to know what triggers the seizures, because there are some things you just cannot control as far as seizures are concerned, and there are some things that you can control, and that is you want to avoid sleep deprivation, you want to avoid skipping meals, you want to avoid overuse of alcohol or other illicit drugs. There have been some case reports of people that overdo it, Benadryl, which is an antihistamine that triggered their seizures. The same goes with people who overdid on aspartame, which is an old artificial sweetener. They have triggered their seizures. And of course, most importantly, if you're taking a seizure medication, you want to make sure that you take it regularly and not miss any doses. And really, just as last slide, just to show you, even Hippocrates, who lived 460 years before Christ, was talking about seizures and epilepsy. So, like I said, the whole thing about epilepsy has been around for a very long time, and some people, like Dostoevsky, a famous Russian author, did not even want to get rid of his seizures if he could, because at the beginning of his seizures he felt like the greatest person on earth. And with that, I am done. So thank you for listening, and if you have any questions, let me know.
Should we unmute people, Dr. Bonwich?
Yes, I unmuted everyone right now.
Oh, you did? Okay.
Yes.
Does anyone have any questions for Dr. Bonwich?
No, apparently not.
Okay.
No? Okay.
Great.
Well, thank you, everyone, for joining, and thank you, Dr. Bonwich.
You're very welcome.
Okay.
Bye-bye, everyone.
Bye.